So we're going to go on to the second lecture of this morning. And remember, this is, again, just a stellar group of individuals who are studying cognition and aging. The next speaker is perhaps one of the most important people in our department. I remember when Bob Heaton was recruited, and Igor Grant knew you well and was very enthusiastic about your coming here. And boy, did he turn out to be right. For the last number of years, Bob has been vice chair for academic affairs. That is a never-ending job. Trying to help people getting promoted, trying to make sure that the evaluations of promotion and of career development has been in your bailiwick, and you've done a stupendous job. You're a distinguished professor in our department, and he has, since 1987, found the time to become one of the founding directors of the UCSD SDSU Joint Psychology PhD program that, in fact, was just recently rated in this group of clinical psychiatry training with research background as part of it. It was just recently rated by one of the major raters as the #1 in the country, which is just amazing. Although not amazing once one sees what goes on there. Your work, or Robert's work, in HIV, as well as cognitive aspects of HIV and the cognitive aspects of hepatitis C, methamphetamine use, have all been incredibly important. When HIV first came out as a disorder, all sorts of theories were going on what it might be. And then, of course, it turned out to be just an awful infective agent that very few of us, myself included, really stopped to think that if these lesions are going on almost everywhere in the body, they must be going on in the brain as well. And so what we're going to hear today from actually one of the people who, with Igor Grant and Chris Hakim and many others who are in the audience today, will be to talk about HIV and neurocognitive functioning. So, Robert Heaton.
Thanks very much, Mark. And good morning. Thank you all for coming. By way of background, the HIV Neurobehavioral Research Program is a collection of multidisciplinary basic and clinical scientists whose work aims to clarify the prevalence, the nature, the neuropathogenesis, and the consequences of CNS effects of HIV and its comorbid conditions. The program itself actually was started 30 years ago under the direction of Igor Grant, and I've been very fortunate to be part of the team since its inception. Currently, the HNRP has 22 funded investigators and 64 active grants. So most of you here probably already know that HIV gets into the central nervous system very early after infection. And due to a variety of neurotoxic, inflammatory, metabolic, and vascular mechanisms can injure the central nervous system, leading to what's called HIV Associated Neurocognitive Disorders, or HAND. Even in the current era of combination antiretroviral therapy, where it's become the norm to have long-term successful blocking or suppression of viral suppression, HAND exists in some 30 to 50% of HIV-infected people. Nowadays, it's typically mild to moderate in severity. It's typically non-progressive, although it can fluctuate due to changes in treatment and other factors. The bottom part of the slide shows the kinds of abilities, the cognitive abilities that typically are infected, and they include, and the y-axis is the prevalence of these problems in people who have hand. And the areas are episodic memory, executive function, attention and working memory, complex perceptual motor skills, speed of information processing, and verbal fluency. This slide shows the current international classification criteria for hand. It was hammered out after a period of some years of interacting with among international experts in the HIV field, and the people in work groups came together in 2005 in a place called Frascati, Italy, and agreed upon the current system. Frascati classifies 3 types of hand, or identifies 3 types of hand. By the way, a number of the HNRP investigators were key parts of these discussions, and that's one of our, I think, major contributions. The first category of hand is called asymptomatic neuropsychological or neurocognitive impairment. And for this, people have to have at least mild impairment of at least 2 of the abilities that I just talked about. But as far as anybody can tell, there's been no effect on the patient's everyday functioning. That's usually that information comes from self-report, which can be problematic, as I'm sure most of us know. The next category is mild neurocognitive disorder, and this has exactly the same neurocognitive requirements. And but in these cases, there's at least some evidence that it's affecting people's everyday lives. And finally, in the CART area is the HIV associated dementia has become fairly rare, and affecting less than 5% of infected individuals. And this requires much more severe cognitive impairment and interruption of everyday functioning. So people with HAD are not able to work and usually not able to live completely independently. Importantly, for any of these classifications, there has to be a judgment that both the cognitive impairment and the functional problems have to be due, at least in part, to HIV and not to the myriad comorbidities that are seen in this population. So one of the major, I think, accomplishments of Frascati was to spend quite a bit of time working out some details, guidelines of how to rate those comorbidities. And they came up with 3 basic categories of comorbidities. The first one is minimal, or synonym for incidental. And these are conditions that may affect some test performance here and there, but by themselves would not be expected to cause people to be overall cognitively impaired. The second category is much more serious, called moderate or contributing comorbidities. And these actually could cause at least mild cognitive impairment and problems in everyday life. But something about the timing, the severity, or the pattern of the deficits also makes it likely that HIV is a factor. And finally, there are severe or confounding comorbidities that are so bad that they can fully explain everything. And so if people have confounding comorbidities, you can't confidently classify them as having hand. This slide just shows a small number of the common comorbidities that are seen with HIV infection on the left column. And it includes various indications of long-term developmental cognitive disabilities. It includes traumatic brain injury, strokes, epilepsy, systemic medical conditions that can affect the central nervous system, complicated substance overdose, usually with cardiopulmonary arrests, and psychotic disorders. So the data in the rest of the slide come from a multi-site U.S. Study that has been coordinated by the HNRP. And the goal of, and it's called Charter, and the goal of Charter was to recruit, without regard to any kind of exclusions or comorbidities, a sample of HIV-infected people receiving care in academic medical centers around the country, and who are selected to be as representative as possible of the general population of infected people. And this shows the baseline information from 1,555 participants. And you see that even the minimal comorbidity people have some of these conditions. By the way, most people with HIV infection don't just have one of the comorbidities, they have a number of them. And, but as you go from minimal to moderate to severe, the prevalence of the comorbidities gets greater. And what we can't show here, also the severity and the number of the comorbidities increase. So not surprisingly, as you go from minimal to moderate to severe, also the prevalence of cognitive impairment goes from 40% to 60% to 85%. This slide shows some structural MRI evidence in support of the validity of the Frascati comorbidity classifications. So again, we're looking at the three comorbidity groups, and on the left side of the frame, you have cortical gray matter volumes. And so high is good, and low suggests cortical atrophy. And you see there's a stair-step pattern here with the incidentals looking the best and the confounded people looking the worst. The middle frame is abnormal white matter, and so obviously high is bad. Again, the confounded people are much worse. And the final frame shows ventricular CSF volume, which is another indicator of atrophy. And it's again the same stair-step pattern. So Frascati got it right to some extent, and this is independent evidence of such. So we always knew that it was in this minimal or incidental comorbidity group that we would likely see the strongest associations between HIV disease indicators and cognitive outcomes. And in the Charter data, we look for which disease indicators were uniquely and most important in terms of predicting outcomes. And we found that if the person never had severe immunosuppression, usually due to earlier initiation of treatment, and currently they have viral suppression on their antiretroviral treatment. If they have those two things, their probability of having cognitive impairment is just below 30%. But if you have the opposite of either of those indicators, the impairment rate shoots up to about 50%. So this slide just intends to summarize a large body of published work, partly from us and done elsewhere, showing that neurocognitive impairment in this population confers increased risk for unemployment, decreased independence in activities of daily living, reports from the patients of struggling with cognitive difficulties in their everyday lives, poor driving, which is Tom Marcotte's work, and used driving simulators as well as on-road testing, troubles faithfully following their medication regimens, poor performance on standardized tests of everyday living, such as medication management, financial management, and standardized work samples, and probably the most important functioning outcome is early mortality, and I'll tell you more about that. This slide attempts to address one of the concerns expressed by some of our colleagues around the country that, well, if the cognitive impairment isn't affecting anything, why should we bother with it? Are we stigmatizing people, and why take the time and to identify them? And so what this slide shows is, in Charter again, if you take the ANI people in the red and the people who are neurocognitively normal at baseline, and you follow them over time, over 3 to 4 years, half of the people with ANI became symptomatic. And this was not because they had greater cognitive impairment, but it was just the fact that the impairment that was there had become recognized over time. So clinically, we would argue that it's important to know that they're at risk for this so that they can be followed and helped. This shows that early mortality information over the longitudinal course of Charter, almost 100 people, actually now more than 100, have died. And we look back at baseline to see what predicts early mortality. And we found that there was no difference at all in baseline demographics. There was no difference in terms of estimated premorbid intelligence. The people who died were more likely to have severe comorbidities, so it's important to identify them. They were more likely to have detectable virus and cerebral spinal fluid, and they were much more likely to be neurocognitively impaired. This shows similar findings from a 2-province study that we did in China, where the people who died in the course of the longitudinal study were more at baseline, where they were more likely to be failing their antiretroviral treatment. They had higher, more depressed mood. They were less likely to be married, so obviously being married is good for you. And they had significantly more cognitive impairment. This shows some evidence from some pathology evidence that of the effects of antiretroviral treatment. So the y-axis here is a measure of synaptodendritic simplification, and so high is bad. And the first bar here is people who are ART naive at the time of death. The second bar is for people who are on treatment, but they were failing at time of death. And the third are people with successful viral suppression on their ARTs. And this synaptodendritic simplification has also been shown to be strongly associated with hand. Next to last slide, this just shows all our international collaborations. We have a similar map of the U.S. with lots of collaborations here, but I'll just mention that we have these collaborations all over, and these different places have different viral clades circulating, and so and there's all kinds of different comorbidities and things that need study. And all the stars show places where we've worked with people in the countries to adapt our cognitive methods and translate them and collect norms. And we've produced age education, gender-corrected norms for the local population, sometimes corrections for other things like urban versus rural status. And so this shows Cohen's D effect sizes in all of these countries. And in these countries, you have extreme variability in terms of people's cultural, linguistic, educational, and socioeconomic backgrounds. And yet, if you get proper norms, and you can measure hand everywhere that we've worked, and there are 7 languages involved here, and so now with the added normative and the skills in the testing, it can be studied all over. So, thank you for your attention.